Greetings, class. This is Nkechi.
And I'm Erica.
And I'm India. And today we'll be doing a HESI case study. No, this is not a real patient. Today we have Mr. Lewin, a 52-year-old man admitted from the emergency department with symptoms of upper GI bleeding. During the night, Mr. Lewin awoke with severe epigastric pain, vomiting, and weakness. Because the vomiting was persistent and contained blood, his wife brought him into the emergency room. In the emergency department, the insertion of a nasogastric tube was done, and with gastric lavage and lab work was also done as well. An upper GI endoscopy is scheduled to determine the source of the bleeding and perhaps treat the bleeding site. You review the orders for Mr. Lewin's care. Since he is scheduled for an on-call endoscopy, we're going to make sure, 1, that he is NPO, 2, the NG tube is on low intermittent suction, 3, strict intake and output, 4, bathroom privileges with assistance, and 5, IV lactated ringers, 150 milliliters per hour. Peptic ulcer disease is suspected. Peptic ulcers are localized erosions of the innermost mucosal layers of the GI tract. Peptic ulcers can develop in the lower esophagus, the stomach, hence gastric ulcers, or the duodenal ulcers. Mr. Lewin tells you that he's had stomach discomfort off and on for years. Recently, he has become more aware of the discomfort. You ask Mr. Lewin to describe his pain in more detail. He complains of burning pain over the stomach region, epigastric pain, pyrosis, which is another name for heartburn, and discomfort, usually in the nighttime after meals. Mr. Lewin states that he also takes N-acids at night for indigestion. Mr. Lewin's lab results have come available. Red blood cell count, hematocrit, and hemoglobin are low, but within acceptable ranges, and transfusion is not indicated at this time.
Okay, Mr. Lewin has GI bleeding prior to the endoscopy. Gastric lavage may be needed, which is to clear the stomach of any blood or clots using room temperature saline. Mr. Lewin's nasogastric tube is vented, which is a double lumen type, and it is attached to suction. The tube does not have an anti-reflux valve. We noticed that gastric contents are leaking from the air vent port, so we are going to instill air into the vent. The air vent needs to remain free of fluid. It is appropriate to instill air or saline, generally a volume of about 10 milliliters, into the air vent lumen to make sure it's clear of fluid. Positioning the air vent above the level of the patient's stomach may also be helpful in preventing future occurrences of leaking. Mr. Lewin has been prepared for surgery. We are checking for NPO status, advising the patient of a sedative being used, local anesthetic for the throat, removal of any dentures, and rinsing consent. During surgery, a duodenal ulcer is identified, distal to the junction of the pylori and duodenal mucosa. Consistent with duodenal ulcers, the ulcer is deep and sharply defined. Swollen but non-bleeding blood vessels are observed. Heat is applied to the blood vessels to prevent rebleeding. A gastric ulcer is also identified at the distal end of the stomach. Gastric ulcers are less well defined. The ulcer is flat and clean and is a low risk of bleeding. During the endoscopy procedure, a specimen of mucosa was taken for biopsy. Helicobacter pylori was identified, which can also be a cause of peptic ulcer disease. Mr. Lewin's GI bleeding does not return over the next 24 hours, and his hematocrit stabilizes at 35%. His NG tube is discontinued, and he is started on oral feeding. Mr. Lewin's peptic ulcer disease will be treated medically with combination therapy using 2 antibiotics with a proton pump inhibitor for the next 14 days.
Okay. Despite compliance with therapy and eradication of H. pylori, as evidenced by breath tests after treatment, Mr. Lewin still has recurrent ulcer development and episodes of GI bleeding. Hemostatic therapies, including intravenous proton pump inhibitors
and various endoscopic treatments are unsuccessful. Mr. Lewin will have surgery, a selective vagotomy, which is cutting the vagus nerve, and also an entrectomy, which is removal of part of the stomach. So pre-op, we want to teach Mr. Lewin about his PCA pump that he will have after surgery. And post-op, we will check vital signs and compare them to his pre-op vital signs. We also want to position him in the semi-flowers position, check his dressing, which is dry and intact, and ensure that his IV infusion and NG tube is working properly. Besides keeping the pigtail port of Mr. Lewin's NG tube above his waist, you want to avoid irrigation or installation of any fluid into the tube unless it is specifically ordered. If the tube appears obstructed, we will plan to notify the physician. Okay, so Mr. Lewin is placed on prophylactic antibiotics after surgery. 3 days later, he is ambulating. Mr. Lewin's NG tube and IV has been discontinued. He has tolerated diet progression from clear liquids to full liquids to regular. So we will prepare him for discharge. During discharge planning, we will tell Mr. Lewin that his peptic ulcer disease will be treated medically with the combination therapy, which is 2 antibiotics and a proton pump inhibitor such as Protonic for 14 days. We will teach Mr. Lewin to avoid the use of NSAIDs and aspirin because they promote GI bleeding. And we want him to stop smoking. Mr. Lewin is at risk for dumping syndrome, which is dizziness after eating. So we will teach him about lying down after meals for about 20 to 30 minutes to prevent rapid stomach emptying. We will also teach Mr. Lewin about the signs and symptoms of GI bleeding, which can include black stool and vomiting of brown bloody fluid. Despite surgery, ulcer disease may reoccur, and Mr. Lewin is aware of these signs of the recurrent disease. That's all, folks.
Happy studying.